My teammate Kristina and Jiona and myself, Maylis, we're going to talk about weight bias and stigma in healthcare. So first of all, is it important for me to mention that the presentation is not made in order to be an attack, of course, but it can be uncomfortable because we realize that we all have been guilty of weight bias, at least once, I think. The goal is to educate ourselves about this and to make the healthcare environment a better place for people living with obesity. So here's a little overview of what we're going to talk about today. We're going to start with some definitions. Then we're going to talk about the impact of weight bias on providers, then on patients, and then we're going to go over some potential strategies to address obesity stigma in clinical care. So the definitions. Firstly, stigma. So it's a physical characteristic that marks the bearer as having lower social value. It can lead to experiences of discrimination, and it can put one at risk for low self-esteem, depression, and lower quality of life. Weight bias is a negative weight-related attitudes, beliefs, assumptions, and judgments toward people who are overweight and living with obesity. And weight stigma is the social sign that is carried by a person who is victim of prejudice and weight bias. So the stigmatization of people living with obesity has increased in frequency and intensity, despite multiple research showing that obesity is a complex genetic condition, and despite obesity being classified as a chronic disease since 2013 by the American Medical Association, 2015 by the Canadian Medical Association, and even 1948 by WHO. 26.8% of adults live with obesity in Canada, and individuals with higher body weight are vulnerable of experiencing stigma and discrimination because of their weight. So while weight stigma can occur at diverse body weights, the highest rates of weight discriminations are often reported among adults with class 2 to class 3 obesity, which means a BMI equal or above 35. And these stigmatizing experiences induce a range of negative consequences for both emotional and physical health, including increased risk of depression, low self-esteem, poor body image, exercises avoidance, psychological distress, cardiovascular disease risk factor, continued obesity, and weight gain. Sorry. So there is empirical evidence that people with obesity elicit negative feelings such as disgust, anger, blame, and dislike in others. These are very strong words, and you can imagine how it can make people living with obesity feel, and no one wants to feel like that. So people living with obesity are frequently the targets of prejudice, derogatory comments, and other poor treatments in a variety of settings, including health care, despite the high prevalence of obesity in North America. So the conscious and unconscious stigmatizing attitudes held by healthcare professionals is a reflection of two things. So first is the exposure to consistent and widespread weight stigma. And two is the lack of training and education for healthcare professionals about the complexity of obesity, as well as how to avoid bias and stigmatizing attitudes that may impact care for people living with obesity. So it also should be noted that weight bias, stigma, and discrimination have been observed in healthcare professionals and student trainees across various health disciplines.
Sorry, I'm presenting. They led me the room.
Including physicians and medical residents, medical and dental students, nurses, dietitians, kinesiologists, physiotherapists, health science students, and even professionals specializing in obesity. So I'm going to let Kristina take over.
Thank you. I'm sorry about that. Someone tried going into the room. So thank you, Maylis, for introducing the topic. I will now be discussing the impact of weight bias on providers. And once again, we would like to emphasize that this is not an attack. We really just want to shed light. And firstly, I would like for everyone to take a few moments and ask yourselves the following questions. So what assumptions do you have about people with obesity? do have stereotypes about a person's character, personality, lifestyle, or health based on their body weight? If so, what are they? And lastly, how do you feel when you interact with people with obesity? I want you all to reflect on these questions while we dive deeper into this topic. Now, how is weight bias expressed in healthcare? Weight bias can be expressed by language, medical equipment, weighing procedures, office environment, health services and care, and provider attitudes and comments. When we talk about language, we could think of insensitive language about a patient's weight. For example, referring to them as fat, chubby, heavy, and so on and so forth. It could also be by expressing insensitive jokes that place people living with obesity as the target of humor or ridicule. In fact, in one study done in 2014, students training in health disciplines reported that patients living with obesity were a common target of derogatory humor by peers, healthcare providers, and instructors. Next up, we have medical equipment. So that could be too small to be functional for patients with obesity, such as patient gowns, examination tables, scales, blood pressure cuffs, speculums, etc. Now we have the office environment. That could be having unwelcoming waiting rooms and medical examination rooms, either due to negative attitudes by office staff, too small waiting room chairs, or reading materials that stigmatize weight, to name a few. Now for weighing procedures, that could be when healthcare providers make negative comments or facial gestures upon weighing a patient. For example, whoa, weighing on the heavy side today, or making a shocked facial expression when seeing the number on the scale. These types of reactions can really bring about feelings of shame and embarrassment in patients. Lastly, we have provider attitudes and comments. This can be due to common stereotypes, such as thinking that people living with obesity are lazy or weak-willed. Providers may also have negative weight-based assumptions and incorrectly assume that obesity is a self-discipline issue, that patients with obesity have lower motivation for health behavior changes, poorer treatment compliance, and poorer adherence to medications compared to thinner patients. Providers may also attribute obesity to behavioral factors rather than other uncontrollable factors, which can consequently exacerbate weight bias in healthcare. There are strong repeated findings that individuals affected by obesity are viewed by a large portion of healthcare providers as awkward, unattractive, non-compliant, slothful, and as I mentioned earlier, weak-willed and lazy. And while healthcare providers are unlikely to intentionally discriminate against their patients, they are not immune to harboring these same views, sometimes without even necessarily being aware of it. This brings me to a concept called inactivated stigma. Inactivated stigma is defined as behaviors of discrimination or unfair treatment that emerge from negative attitudes about a stigmatized group. Inactivated stigma can in fact reduce the quality of patient-centered care. The negative attitudes underlying inactivated stigma can either be explicit or implicit. So when we talk explicit, that would mean that it is conscious or deliberate and reflects a person's opinion or belief. And that could be, as I said, through derogatory jokes. In fact, in many Western cultures, it is quite acceptable for people with obesity to be the source of derogatory humor and thus may be openly and unquestionably be portrayed as lazy, glutinous, and undisciplined. And this can occur in movies, TV shows, comedy skits, and unfortunately, even in healthcare settings. And when we talk about implicit, an example could be how during medical visits with people living with obesity, physicians with greater implicit weight bias may sit further away from their patient, use less visual contact, be less engaging, to name a few. And so it's really unconscious and automatic, and often occurs involuntarily and outside of one's own awareness. We often assume that a person living with obesity is inactive, eats poorly, or does not care about their health. Many also assume that all people living with obesity want to lose weight and need to be encouraged to do so regularly. Furthermore, physicians often incorrectly attribute patients' health concerns to their weight, implying that their problems would be resolved if they lost weight, despite many weight-associated conditions also being common in normal weight individuals. The mechanisms by which provider attitudes can affect the quality of patient-centered care are engaging in less patient-centered care communication with patients they believe are less likely to be adherent, less respect for people living with obesity than those without, and even going as far as allocating less time in providing health education to people living with obesity because, oh, what's the point? They're not even going to do it. So we selected this picture here because we thought it properly illustrated the point we were trying to bring across in a very dramatic way. So you've got a patient walking into the clinic saying, "Doctor, I've been impaled." And the doctor responds with, "Well, maybe you'll feel better if you lose some weight." Now, we're not saying that this would necessarily happen in a real life situation. However, it really goes to show the attitude that certain providers may have when dealing with people living with obesity. Oops. And that brings me to a few testimonials that we got from the Obesity Canada website. In fact, it was a document prepared by Obesity UK. And so I'm just going to read a few. On the left in blue here, we have a person living with obesity who said, "Had a doctor's appointment to discuss suspected endometriosis. As I was being examined on the table, stripped naked from the waist down, the doctor grabbed a handful of my belly fat, jiggled it about, and announced to the nurse, 'She needs to get rid of this first.' My GP told me I was a drain on the NHS, needlessly taking the contraceptive pill. She said my weight would stop me ovulating. I was pregnant 2 months later, and then I was called irresponsible by the consultant for getting pregnant. Visiting my GP with chest pains to be told to go home and look in the mirror as that was what was wrong with me. So later that evening, being rushed into the hospital because I could not breathe. I was diagnosed with bronchitis. And then we have the case of Ellen Maud Bennett, a Canadian who for years of feeling unwell had sought out medical intervention and no one offered any support or suggestions beyond weight loss. She was finally given a diagnosis, terminal and inoperable cancer. She was given only days to live and died on May 11th, 2018. She actually used her obituary to give one final message about the way she was treated by the medical profession and said her dying wish was that women of size should advocate for their health and not simply accept that fat is the only relevant health issue. This really illustrates how flawed the system can be and how certain providers continue to prioritize weight loss as a primary outcome and rarely consider patients' experience, quality of life, or adverse events. Weight loss in people with obesity can be positive, but interventions that strive for weight reduction at any cost and without regard to the patient's personal, social, and environmental context are not in anyone's best interest. On that note, I will pass along the mic to my colleague, Jiona.
Awesome. So thank you, Kristina. Now I'll be going over how weight stigmatization can impact our patients. So first off, I do want to outline some weight determining factors. So scientific evidence shows that people have little choice and control about their weight, just due to the fact that there's a multitude of factors that really interplay. So there's genetics, which is one of the biggest factors. There's race, ethnicity, age, medical conditions, and medications, environmental factors, sleep, food security, and the list really goes on. Eating behaviors can affect weight as well. However, it is important to remember that weight determinants are multidimensional, and diet on its own is not the only factor that determines your weight. Now, I want to highlight an interesting observation I made while looking up some vocabulary words on Google. So what do you think pops up when you type in healthy person in your search engine on Google? So the image here on the left is actually the first picture that pops up. And it's a woman who is thin. She's holding fruits and vegetables in one hand and a dumbbell in the other. She is smiling and looks generally happy with life. And the other images that pop up always include someone in a thin figure, and they're doing some sort of exercise or activity. And generally, these images idealize these characteristics. On the other hand, what do you think pops up when you search unhealthy person on Google? So here, once again, oh, too fast. Here on the left is the first picture that shows up. And it's a person in a larger body holding quote unquote junk food. And this person is holding fruits and vegetables in one hand and a burger in the other, but he is eyeing the burger. He is frowning and displays unhappiness. And other images I observed included people sitting on a couch or a chair, and they looked generally displeased and unhappy with life. So these two images paint completely different lifestyles. The first image is something that is idealized and more wanted in society, whereas the second image is seen as non-desirable. So this brings me to the negative judgment towards higher weight individuals that is omnipresent in today's world. So Kristina already mentioned some of these traits that are often stereotyped with individuals living in higher weights. They are seen as unhealthy, a burden to society, having poor lifestyle habits because it is believed that weight can be controlled. They're seen as lazy, unmotivated, lacking willpower, gluttonous, and incompetent. However, a person living with obesity does not automatically have these traits. It is very much possible to be healthy and live in a higher weight. So this is a theoretical model that showcases variables that are associated with weight stigma. This model is pulled from a study comparing weight-inclusive and weight-stigmatized groups. And the study demonstrated that there were no benefits in health interventions that promote weight stigmatization. In fact, there were adverse effects. So weight stigma leads to internalized weight stigma in both the health professional and the patient themselves. And this leads to appearance monitoring and body shame, both internally and externally by projecting onto others. And this is most often done non-intentionally. This ultimately leads to decreased physical and psychological health and well-being. I also want to mention that these factors are in fact intertwined, which is shown by the blue lines, and they can lead from one factor to another, not necessarily following a step-by-step movement. So weight stigma only really leads to negative health outcomes. When a patient experiences weight bias during a consultation, they leave feeling unheard and less inclined to visit again. Often the blame is put on themselves, and they feel a sense of incompetency and judgment. There was a 4-year longitudinal study that showcased patients who experienced weight stigma were 2.5 times more likely to become obese than those who were not stigmatized. Weight-related stereotypes often led them to increase caloric consumption, as well as significantly decrease exercise and health intentions. So it goes to say that if reaching and maintaining a healthy weight continuously fails, this is not a sustainable nor healthy solution, but a temporary fix. In a meta-analysis study of 29 studies altogether, there was structured weight programs that were studied upon. And participants regained 77% of their initial weight loss after 5 years. Many individuals who complete a weight loss program actually gain more weight on top of what they lost, especially if it is a drastic weight loss program. Think of The Biggest Loser, a pretty intense and really toxic weight loss program that is offered in the United States. The participants in that program, they lost a drastic amount of weight in a very short period of time. And that's just due to the nature of the show. These individuals regained their weight after a year of terminating their program, and many of them gained more weight than what they lost. Weight cycling, also known as yo-yo dieting, is a common result of dieting. And this is when an individual goes through drastic weight fluctuations of weight loss and weight gain. Weight cycling has a negative effect on metabolic and psychological well-being. Metabolism will fluctuate by dieting, decreasing an individual's base metabolism and requiring less energy in order to gain weight. Psychologically, individuals can develop unhealthy relationships with food and disordered eating tendencies, or even diagnosed eating disorders, such as binge eating and bulimia. In fact, weight cycling is currently being researched and debated as to whether it has a greater impact on disease risk than obesity. So I'll pass it back to Maylis to go over some of the strategies that us health professionals can implement in our practice.
So thank you, Jiona. So as Jiona said, weight loss interventions don't work. So we're going to go over some potential strategies to address obesity stigma in clinical care. So the first one is to increase provider empathy through perspective taking exercises. So there was a study done, and it consisted of imagining sorry, I have trouble with this word imagining yourself in another place to stimulate moral action. So perspective taking exercises could improve provider attitudes towards stigmatized group. The second strategy is to alter perceived norms regarding negative attitudes and stereotypes about people living with obesity. So there is one study in which researchers reduce explicit bias against people living with obesity by providing individuals information and evidence that their peers did not hold negative attitudes towards people living with obesity. So it was 3 experiments, and in one of them, participants decreased negative and increased positive stereotypes after learning that others held more favorable attitudes toward people living with obesity. Also, to minimize the perception, sorry, I wasn't done with the second one, thank you. So also to minimize the perception that anti-fat bias is the norm, one strategy could be to implement a zero tolerance policy for comments or humor that stereotypes or degrades anyone based on attributes or physical identity. So the third strategy is to encourage provider instruction and practice in emotion regulation techniques that foster positive affect. So we all know that working in healthcare system includes high cognitive load and time pressure, and it can impair judgment and decision making. So provider may feel frustrations toward difficult or complex patients, or patients with their perceived or harming or their own health, and it may elicit strong negative emotions. So evidence from one study suggests that emotion regulation tools such as meditation or deep breathing may help providers overcome these negative emotions and improve compassion. So the fourth one is the untested strategy, but it could be to encourage providers to examine their explicit beliefs and stereotypes about people living with obesity and complete an assessment of implicit attitudes by taking the online implicit association test. So there was a link, so I did one of them. There was a lot of different tests. It was one that measured the strength of association between concepts. So it was exercising and relaxing, and attributes, it was good and bad. So the main idea is that making a response is easier when closely related items share the same response key. So we would say that one has an implicit preference for exercising relative to relaxing, if they are faster to categorize stimuli when exercises and good share a response key relative to when relaxing and good share a response key. So my data suggested a strong automatic preferences for exercising than relaxing. And I realized while I was doing the test that I had some bias about relaxing and exercises because I was way faster to categorize the words when good and exercising were associated together. So I think it could be super interesting to do this kind of test with weight bias, because I realized while I was doing the test that I had some bias. So it could, it could provide information about the automatic nature of these attitudes and encourage providers to behave in ways consistent with helping and egalitarian values. And the last strategy is to educate providers on the genetic, environmental, biological, psychological, and social contributors to weight gain and loss. So providers who understand this complex web of causality have more positive attitudes about patients with obesity. and it could be less threatening for their patients than using oversimplified messages like eat less, move more, for example. And here's a little infographic explaining why the advice eat less, move more is a bad one. So first of all, it ignores determinants of health. Then exercise, it doesn't burn as many calories as we thought. It's condescending and vague, very vague. And what and how we eat is dependent on our relationship with food. And it's used to shame and degrade people living with obesity by oversimplifying a complex situation. And lastly, it perpetuates myths of diets, willpower, and self-control. So clinician recommending weight loss to patients is actually what causes weight cycling and increasing weight over time and metabolic complication.
Now for strategies for providing a welcoming and less threatening healthcare environment. The first strategy would be to shift from focusing on weight to health behaviors. For example, screening for the diseases and conditions for which obesity is a risk factor, and encouraging feasible behaviors that will improve health and well-being. This could be accomplished by asking patients if they would like to be weighed. It's also important to bear in mind that increasing patients' knowledge of the health effects of obesity has shown little effect on weight loss, according to research. However, encouraging patients to not focus on weight or weight loss, but rather on the benefits of physical activity and healthy eating may reduce the threat of conversations about these behaviors and thus increase the likelihood of behavior change and maintenance. The second strategy is to adopt patient-centered communication strategies, for example, motivational interviewing, which may be less threatening for patients and are associated with patient adherence and positive outcomes. The third strategy is to ensure that the clinical environment is welcoming by providing chairs and medical equipment that are usable by patients of all sizes, and keeping specialized instruments for people living with obesity readily available for clinical staff. The fourth strategy is to convey a sense of identity by providing evidence that diversity is valued by posting a mission statement that stresses the value of body size diversity, and using positive and non-stereotypical images of people living with obesity in clinical advertisements, pamphlets, or artwork.
So that brings me to the HAES model, which stands for Health at Every Size. And this is another solution that health professionals can practice and implement into their own strategies. So like the name suggests, HAES demonstrates that health is not a one-size-fits-all, and it comes in a variety of shapes and sizes. The major takeaways are to reject weight, size, and BMI as a determinant of health. These numbers can help guide your practice, but should not be an automatic indicator of an individual's health. BMI is a ratio of an individual's weight to height, but it was invented in 1830, and that is a whopping 200-year-old invention. Yes, it can help us guide our practice, but categorizing health and diagnosing patients with just these values, that is not very ideal. Refute the myth of weight being a result of personal choices and ignoring other factors like genetics, environmental factors, and medical conditions. Remember, there are so many factors that play into an individual's weight. Focus on the role of the factors that contribute to an individual's weight and not the number on the scale itself. For example, if a patient experiences food insecurity and cannot afford healthy foods, target the issue of food insecurity playing a role on the patient's health instead of the weight. Offer cheap, healthy foods in these scenarios that will yield a better outcome than simply telling them to lose weight and eat healthy. Remember that health comes in a variety of forms, like physical and psychological health for sure, but it also includes quality of life. As health professionals, we always want to respect a patient's choices and their definition of quality of life. And last but most definitely not least, encourage intuitive eating. Tell your patients to honor their hunger and satiety cues and listen to what their body is asking for. So these are the 8 principles outlined in the HAES approach. Do not harm, create sustainable and long-term solutions, keep a process focus rather than a day-to-day or end goal focus, provide interventions that have been backed up by evidence-based science, practice diversity and provide care that is unique to each patient you care for, provide access, opportunity, freedom, and social justice for your patients, keep a holistic focus and approach, and move towards a greater health for your patient. So the major takeaways of our presentation today is to just highlight the fact that weight stigma is significantly present today, and it seeps into our healthcare setting. As health professionals with the best interest of providing healthcare for our patients, let's continuously challenge these principles to better our patient-centered care. At your next encounter with a patient, I encourage you to practice an empathetic lens and minimize assumptions. Incorporate the Hayes model into your practice. So now I invite you to share these concepts and ask questions to yourself and colleagues on a regular basis. Thank you for tuning in and providing your undivided attention today. I will invite you all to ask any questions if you have, either unmute yourselves or pop in the chat box.